Okay, just so we stay on track, let's go ahead and get things started. And as folks continue to come in, feel free to say hello in the chat. But we're going to kick things off now. So welcome everyone to our webinar today on addressing social needs and efforts to prevent and reduce cancer. We have a really exciting discussion and very interesting panelists lined up for you here today. So before we get things started with our discussion, I want to introduce today's moderator to you all. Dr. Amelie Ramirez is an internationally recognized researcher in Latino health promotion and behavioral change. She's the director of Salud America and its home base, the Institute for Health Promotion Research at UT Health San Antonio. She spent over 30 years directing research on human organizational communication to reduce chronic disease and cancer health disparities affecting Latinos, including things like cancer risk factors, clinical trial recruitment, tobacco prevention, obesity prevention, and the promotion of health equity. So welcome, Dr. Ramirez, and thank you for being our moderator today.
Great, thank you so much, Julia. We have a wonderful panel for everybody. We want this to be very interactive, so please, any questions that you might have, place them in the chat or be ready to let us know how we can help and work with you. Today, I'd like to welcome you to our second webinar of our 6-part series on health equity. We are really serious about trying to change how things are being done here in the US and in terms of truly improving health. To make a difference in cancer, we really have to reach our underserved populations. And so that's why health equity is such an important topic for us. Many cancer patients, not only in South Texas, but throughout the US, have barriers in terms of access to care. Some of those barriers stem from where they live and what transportation methods they have to get to and from the hospital or to the clinics. Another barrier is lack of insurance, as Latinos have the highest uninsured rates of any other racial or ethnic group. There are also barriers within a hospital system. For example, there could be cultural and linguistic barriers between healthcare providers that can prevent Latino patients from receiving the adequate care that they deserve. Additionally, improving health education efforts to inform Latinos of opportunities for care, such as clinical trials and preventative screenings, are so important to make a difference. Today, we're going to discuss some of these perspectives from a healthcare provider standpoint, looking at what policymakers should be doing or could be doing, and how our community health workers are helping us tackle this important issue. Thank you so much for caring about this particular issue and others that'll be coming up, and for being here with us today. Before we get started, I'd like to give a special thanks to our webinar sponsor, Genentech. Genentech is a biotechnology company and a member of the Roche Group. We are thankful to be funded by their new initiative to promote health equity and diversity in STEM, that is science, technology, engineering, and medicine. Here today to talk more about their efforts and to promote patient inclusion is one of our panelists, Megan McKenzie. Mrs. McKenzie is the principal in patient insights and health equity and the chief diversity officer at Genentech. In addition, her background is in medicine, clinical research, biotech health, and she guides Genentech's work in looking at health equity and patient inclusion. So Megan, thank you so much for joining us today.
Thank you for having me.
And then we have 3 additional panelists who will help us learn how to explore strategies and system-changing advocacy systems to improve Latino enrollment in clinical trials. We'll be talking to Dolores Garcia. She's a research assistant area specialist with our Institute for Health Promotion Research here at UT. From Dr. Luz Garcini, who's a clinical psychologist and associate professor at the Center for Research to Advance Community Health at UT Health San Antonio. And we also have Kyle DeLeon, who is a Texas grassroots manager of the American Cancer Society's Cancer Action Network and is a cancer survivor. We want to hear from the audience, so please make sure that you list your questions in the chat. But let me start by asking Megan, how is Genentech working on improving access to healthcare and improving diversity within the healthcare systems?
Thank you, Dr. Ramirez, and thank you for hosting us today. It's my honor to be with all of your experts in the room. Just a quick personal note, my very first job in clinical research was as a coordinator in San Antonio. So Dolores, I envy you. I miss direct patient contact. Patients have really guided us in everything we do, and I have found that patient insights cause behavior change. So when folks get stuck in their bubble, they've run that oncology trial before, they have done this before, they've seen these patients before, what really stops them is seeing patients, having patients in the room. So I'm very lucky, Dr. Ramirez, to be a part of the Chief Diversity Office, where we are invited to bring patients and have a patient co-creation council that we ensure are diverse. And in the Chief Diversity Office, so I've worked in clinical research for about 25 years, but in just 2 years in the Chief Diversity Office, where I am learning, we directly report to our CEO, and that plus the proximity to our officers have allowed us to create these strategic pillars. One of them, foster belonging with our people, ensuring how are we ensuring we have Latino representation at all levels of leadership in the CEO suite, director to VP. And one of those pillars is advancing inclusive research and health equity. And it allows us to have goals which are visible for all 149 officers in our Air Health Equity pillar. And I'm very lucky to be working with partners in patient advocacy, actually Kyle ACS for back to screening, Dr. Ramirez with you at UT and Salud America. We very much understand we need to listen and learn and lean into partners who are living in this space, understand cultural competency. And one of my main roles is starting to bring in education around cultural competence, which very much have appreciated Salud America's partnership, Dr. Ramirez, your group's partnership in building culturally competent material, things like the clinical trial animation videos with representation lens, working with Dr. Sandoval with Tu Salud, Tu Familia for patient education. So a lot of my work is centered on education and how can we do that better? How can we message things so it makes sense, it's distilled. Everyone, HCPs and patients have this deluge of information. So how can we help funnel information that patients want and HCPs need? And very much appreciate the partnerships of everybody in this room. So enough about me. You can
Well, thank you so much, Megan. No, you hit the nail on the head. I mean, I've always said that, we need so much more education in our community so that they better understand what is cancer, because the first thing that comes in their mind is how fearful they are when they're given that diagnosis. So we really need to educate them in terms of what steps they can take to come in for early screening, because we see way too many patients that are coming in and being diagnosed at a later stage. So thank you so much for all the efforts that you and Genentech are doing. Now I'd like to go to Dolores and ask her. She's really just coming up the ladder, and we're really excited for her. She is our current research area specialist, but prior to that, she was a community health worker. Can you talk about how community health workers can support cancer patients?
Yes, of course. Hello, everybody. First of all, thank you so much, Dr. Ramirez, for allowing me to provide the community health worker perspective. I do believe it's really important to get the community health workers experience that we're the ones having the interactions with the patients and with the community. And so it's really important to get our point of view out there. And I'm so glad to be a part of this wonderful today. So how do community health workers support cancer patients? So I think a really big way that we support cancer patients is through patient navigation. I think that is a big part in our role that we play in terms of patient care. So in what ways do we help patients? So for one, we make sure that they schedule in terms of patients who are maybe due for their cancer screenings, make sure that they schedule their mammograms, their colonoscopies by providing, calls, reminder calls, making sure that their scheduling goes through to the correct department and that they actually complete their screening. We provide education about the importance of regular cancer screenings, maybe some clarification of myths, the importance of early detection and early treatment. We also assist with any barriers that they might have to completing their cancer screenings. For example, some transportation. Sometimes some of our patients struggle with the transportation to our health center. It's a little bit far away from them. You know, I think if we think about San Antonio and how San Antonio is spread out, a lot of our Latino communities are pretty far away from our health center, and so transportation is a big one. And of course, as you mentioned before, Dr. Ramirez, financial assistance is also something that we try to assist as much as we can with our cancer patients, but also with patients who might be needing some cancer screenings, or who might have cancer screenings coming up. We provide reassurance to them that they will not be harmed with cancer screenings. That is a big fear that we hear in our communities and in our cancer patients and in our patients in general, is that fear that cancer screening is going to cause them some sort of harm. And we just want to reassure them that their doctors want to provide the best care for them. We remind them that cancer screenings are a form of cancer prevention. And we assist with helping cancer patients or cancer survivors obtain any community resources that they might need. So, you know, if they need any food pantries, if they need help finding a support group in their area, or if, again, they need any help connecting to sources of financial assistance. So those are just some ways that we help our cancer patients, but also just our general patient population in terms of getting them their cancer screening.
Great. No, thank you so much, Dolores. What do patients tell you in terms of the help that you've provided them? How do they feel?
Oh, the patients are very, very grateful. I think a big thing that community health workers provide is being that bridge between the patient and the provider. A lot gets lost in translation, or a lot of patients fall through the cracks without any intention. It's just how our system is built. And so, you know, the patients just providing that extra phone call to make sure that the patient knows that their mammogram is coming up, or to make sure that they're doing okay in terms of their cancer care, or that they were able to find the cancer care that they needed or the resources that they needed. I think patients just generally appreciate, you know, us taking that moment to call them and make sure that everything's okay. Patients are generally very grateful, and they're very, you know, we also provide a lot of help to close those gaps. So whatever we hear from the patient, we can directly, you know, provide that information to their PCPs, to their whatever kind of provider they're looking for. And I think that just really closes those gaps that sometimes are created between patient and providers.
Great. Thank you so much, Dolores. Now I'd like to go to Dr. Garcini. Garcini, you've worked extensively with the Latino communities as a healthcare provider. What do you see as the main way healthcare providers should address social needs of our patients?
Oh, hi, Dr. Ramirez. Thank you. Thank you for the opportunity to be here above all. And thank you for that beautiful question. And if I have put it into one word, I think providers need to be humble and have humility. And a lot of the times we seem to forget that our patients are experts in their own life. You know, we might have the tools to help them, but we need to acknowledge that they also have the knowledge about their lives and their situation, what they need. And I think breaking that power differential between providers and patients is very important to create safe spaces for our patients so that they feel comfortable to bring on board all the compounded health issues that they often present with. You know, I think also the ability to work, I love hearing what Dolores was mentioning. I mean, community health workers are, I call them the eyes, the ears, and the heart of our community. And I think as providers, we need to learn to listen to our community health workers, communicate with them, use them as sources of patient navigation. It's very complicated to navigate healthcare systems. So having someone who can lead you by the hand, who can give you basic strategies, how to do lists before you meet with a provider, and then coming into a room knowing that you will provide a voice to the patient, it's so important for that. So I would say that overall, that is key to start advancing in helping patients be more open about what's happening to them so that we can help them.
Great. Yeah, and being that bridge with them so that they're not so fearful, right? In terms of, coming into a sterile environment, you're not feeling well or not knowing when what kind of a diagnosis you're going to get really also intimidates our patients. So how can we really show that cultural humility in working with our patients, I think is so important, and your work has been so valuable. So thank you so much. Kyle, what is the current state of policy and systems when it comes to supporting our cancer patients on a statewide basis? And how do you go about doing your work?
Well, thank you for having me here on this panel. I'm very proud of the work that we've been able to accomplish at the American Cancer Society Cancer Action Network within the state boundaries. I mean, we do have some federal work, but here in the state of Texas, I'm sure most people on this call are quite familiar with the Cancer Prevention and Research Institute of Texas. That is a bond-funded initiative that is a new state agency, or relatively new, that was created with the intention of preventing cancer, researching cancer with state-funded dollars, making Texas the second largest funder of cancer research, just behind the federal government. Aside from CPRIT itself, there's a number of other state-regulated programs, such as the Breast and Cervical Cancer Screenings Program, the Texas Cancer Registry, and we also have tobacco control programs and other state-funded programs that are in the similar field of cancer prevention. But I think that one way to really distill this in terms of the impact of like ACS CAN, we're really proud of CPRIT not only being created, but being renewed in the 2019 legislative session. So it would be continued from the initial $3 billion bond to $6 billion. So just a continuation of another $3 billion over the next 10 years. That creates a ton of opportunities for researchers in this state to find new cures, find new advances, study new samples of people. And one thing that's really important to remember when we're talking about diverse populations of any sort is that the wider swath of samples that you get, the better your data is going to be, and the better that your cures and treatments will come from that. At ACS CAN, we're really proud of staying abreast of evidence-based policy proposals that would drive the biggest impact in whatever region that we are working at that time. Here in the state of Texas, we've noticed that there are certain pockets of higher incidence rates of colorectal cancer, and there are certain pockets where there are higher incidence rates of tobacco usage. One thing that I'd like to highlight from the 2021 legislative session, ACS CAN was able to lead a coalition to pass a bill that lowered the age of covered colorectal screenings from 50 to 45 on state-regulated programs or state-regulated insurance plans, so that following a non-invasive positive stool test, that the patient would be able to go all the way through to a colonoscopy without having to worry about additional costs. And these cost barriers end up being a driving factor for a lot of patients deciding that they don't want to go down that road, because they'll hear, oh, my cousin went and got a colonoscopy and she got, a $4,000 bill in the mail, or $2,500 based on whatever their deductible was. And that would cause someone to think, oh, well, maybe there's just a little bit of bleeding. I don't need to worry about that. When no, bleeding, it's not okay. It's bleeding is not normal. So trying to reestablish where our public policy lands on people is how we at ACS can, I guess I'm talking in a circle because this is a circular process, right? Because we take these stories of people who have been affected by where the gaps in policies exist, utilize those stories so we can close those gaps for the future. And it's a long process at times. Sometimes it takes years, sometimes it takes several sessions, and having that same person and a growing number of people who have similar stories in front of lawmakers for them to understand that this is not a one-shot thing. This is not just happening in this one town. This is something that's happening across multiple cultures, multiple geographic regions. And it's a long process, but it's all worthwhile when you see victories, big and small, and big victories like CPRIT, big victories like the colorectal bill, and then even I don't want to minimize the importance of the BCCS program, but keeping that funding going, I feel like it doesn't get the rah-rah that it should, but that funding is consistently at a threat. So you have to really think about the fact that this funding at any point in time can be pulled legally. So it takes a concerted effort to keep your eyes on the ball and keep your eyes on these systems so that we don't fall behind in these ways that legally we could.
Right. And in particular here in Texas, right, where our Medicaid coverage is quite low compared to other states, we really need to fortify these efforts to help our patients, receive coverage from different standpoints. So thank you very much. I'm going to go back to Megan. Megan, you raised an important point as you were listening to Kyle's remarks in terms of the need to increase the biorepository samples from our underrepresented minorities. How did Genentech get interested in this issue?
We're very science driven, and we recognize there's an ethical, right? We need to make sure that we've got heterogeneity patients in our trial research, but also in our repositories. When we think about the ethical perspective, right? Patients in our trials should mirror patients who have the disease. We can't assume the safety and efficacy parts of our investigational new drugs are generalizable. And I'll give just one story, it is so important representation, even early. We had a super responder. An East Asian woman was in an early trial. We discovered a new allele because of her. We had this Tarceva, we had lung cancer, we had other responses, but she was 100 times a super responder. And the researchers looked, why did she, of all the others, respond differently? And they found this new allele, which became a target. I don't know if that drug would have gone forward if she hadn't been in that trial, because there are other things that are treating lung cancer, and maybe that wouldn't be where you would focus. So even early, and I'm a melanoma ×2 survivor. I'm very lucky, caught early, had enough procedures to feel, this, how do you manage this, right? Where you're going through it, but very, very lucky. And I'm part of a repository because I know the more information is better. So we value highly and are trying to partner with others to increase the heterogeneity of biosamples, the very samples on which researchers are trying to find new targets, test new medications. And we realize the heterogeneity right now, more than 90% of European ancestry, mostly white folks. And guess what? When you're trying to find the incidence and prevalence of biomarkers in a population, you're going to be finding them mostly in white folks. So we really, really, really need our Latino and our Black communities to contribute and be able and know that there's privacy. I think there's this, we talk about fear, like, ooh, what are people going to do with my data? Privacy, double anonymized. Your physician, of course, has information, but we don't. It's highly secure and regulated. So just the value with which we can understand new targets alone and develop medications that might be more appropriate in different ancestral populations, but also just understanding safety and efficacy differences. We look at, there was a novel gene variant in breast cancer because we specifically looked at Latino women. And the new discovery, and there's safety differences. I think like carbamazepine is a good example, Tegretol for convulsions. In East Asian patients, they have severe and sometimes even fatal rash. We need to know that early. So not to scare people more, but under high monitoring safety protocols, making sure we have folks that are included. But that's the biological and safety reasons. There's obviously a huge ethical reason to make sure we're not leaving any patient behind. And I heard you, Dolores, about rural populations who are not close, maybe don't even have a hospital in their county, agricultural farm workers. We're looking at rural and agricultural farm workers and their inability to access medicine because of under and uninsured. And Dr. Ramirez, you know this, but working with the Greater Farmer Organization, over 30 farmers, there's a medical assistance tool that gives you access to all pharma companies' access programs. So I'll put it in the chat, but it's not just Genentech, right? Everybody has access lines to provide, to handle copays or depending on certain family income levels, giving their meds. So I'm going to put that in the chat because that access piece, sorry, I went and answered a different question, so I'll stop. But yeah, obviously I have a lot of passion in the area. So Kyle, thank you for bringing it up.
No, very, very important, very important. Dr. Garcini, what is unique about South Texas Latino community when it comes to health?
Oh, wow. That's a very important question and big. You know, people tend to think of Latinos as one population. And in fact, there's so much heterogeneity in the Latino population. We vary not only by country of origin and immigration history, but we vary in acculturation status, in how the proficiency of the English language, in how much we affiliate to traditionally Latino cultural values, or how we have acculturated to US values. So there's tremendous amount of diversity in myths, in beliefs that we have about health and illness, in behaviors that we do, in the composition of our families. Some families are focused on the nuclear system, whereas some families traditionally have more extended families. And I think a lot of the times when people conduct research, they think of Latinos as one single group without really looking at the diversity of the experiences. You know, and we also vary across genetic variants. So it is important that researchers and providers become aware that definitely Latinos is not a one-size-fits-all mold, and that we start looking at what are some within Latino group differences that are important to address, because we need interventions that need to be tailored to these different groups. We need treatments tailored to the different needs. Dolores was talking about the beautiful work they do in the provision of resources. So we need to think what resources are needed for each of these different groups of Latinos that exist. So that is definitely an area that we need to master if we are to move towards health equity.
Great, thank you so much. And you're so right in terms of the diversity. You know, I always like to use the term that, you know, it's anywhere from European, you know, to Afro Latino and Native American in between. You know, so we've got all this wide variety of the Latinos, and that kind of leads back to the biorepository, why it's so important for our Latinos to participate and share their biological samples with us. So thank you. I wanted to go again to Dolores. And Dolores, how has working with the community made you a better research specialist?
Oh, wow. That is a really, thank you for asking that question, because I always say, and I continue to say, if I wouldn't have had that experience, the first 4 years of public health, in the public health field as a community health worker, I wouldn't have the same lens that I have now as a research area specialist. And I'm so grateful for my first, you know, interactions with public health being as a community health worker, because it took me into these areas, physically into these areas where with lower income, historically marginalized groups. And so I sat there with them. I listened to them firsthand, listened to their needs, listened to their fears, listened to their reasons of why they don't go and, you know, get their regular checkups, and their reasons for not, of why cancer screening is probably not the first thing in mind, because they have all of this list of other 10 things that they have to worry about. And a lot of it is, you know, first I got to put food on my table, and then number 20 can be cancer screening. And so it was really, you know, impactful, and it was really eye-opening to have this experience to go and provide this health education about how we can help them and provide resources to them and let them know that somebody's listening to them. And then, you know, just to see how grateful they were, and then coming up to me as a health educator and saying, thank you for coming out here and providing this information for us. And just those were the most rewarding times of my life, because just knowing that somebody was listening to me was just very impactful. And so now, as a research area specialist, I work a lot with community health workers, and we're working on the integration of community health workers into the clinical setting. And so that's me bringing in, you know, this lens of a community health worker. I'm able to think about what was I hearing from patients, from community members, and how can I integrate it into this project so that our CHWs are providing that very specific care that our community needs. So it's been very, very helpful in this transition to my new role.
Did you utilize any different approaches in reaching men and women?
Do I? Well, when I was there is something that I noticed when I was a health educator was that the people usually coming out to listen to my presentations were women. And so these women, especially when talking about, there's this common misbelief in the community, and I don't know if I'm the only one who's seen this, but a lot of women thought that colonoscopies were only for men. And so it was really interesting for them to say, oh, I didn't know I had to get a colonoscopy too. I always thought that was just for my husband. And and then for them to know that it was also for them, but then also saying to me, oh, I'm going to take this information to my husband as well. And so I didn't get to see a lot of men, but the few men that I did see coming into my presentations they were very impactful, and it was just providing them that knowledge that they weren't aware of. And so now in the patient lens, a lot of our men don't answer a lot of our calls, and it's usually the women, or it's usually the wives that answer our calls and say, oh yeah, I'll get that scheduled for him. And the men are typically the ones that don't answer our calls, and we have to go to extra lengths to be like, let's send that my chart message, or let's try something different for the men. So it is a little bit more difficult to reach the male population than the women are usually more involved in these.
Great. Thank you so much. Dr. Garcini, we have a question from the audience from Laura Celaya. She's asking, what's being done to build trust in our community to participate either in clinical trials or, contributing to biorepositories?
Yeah, I greatly appreciate that question, and I was answering a little bit part of it on the chat. Absolutely. I think it is mistrust, and fear are primary barriers to access. One of the primary things I think that needs to happen, and this has been taking place in some academic medical centers, is we need to take a two-step approach. The first one is a reparation approach. So these communities need to hear and be acknowledged for the damage that has been done. They need to know that we are aware of that as a problem. Because if not, communities feel that they've been dismissed and be constantly abused by that. So I think that is the first step, and it requires a lot of education and a lot of putting the face there to build that trust and to acknowledge that there was a problem. We also need a lot of diversity in the field. Community wants to see people in leaderships that look like themselves. So that is another essential part. But the second point that is important is the instrumentation focus. Communities need to hear that we cannot achieve health equity without them, that they are instrumental in doing this change, and that they can be the guide as to how to do it. So for instance, in one of the recent evaluations the study that I was conducting to find out what are some of the barriers for Latinos to participate in clinical trials for Alzheimer's disease. One of the things that we heard that people say, we want researchers to come to us. We cannot go to them. That's the first step. So all of the stuff that we do in our research labs, we need to be able to accommodate it. Our biomarkers need to be developed in the way that we can conduct these studies in the community where the people are. We also, in order to build trust, we need to learn to give before we receive. Dolores mentioned this. This is what CHWs do. They build resources. So build resources, put programs that are free for the community so that the community can start associating who is giving with the person that is asking. But I think the giving before we ask is essential if we're ever to build that trust.
Beautifully said. Thank you. Thank you very much, Dr. Garcini. Kyle, we have a question from Jorge Moreno in the audience, and he's asking, Hispanic community is high users of a lot of social media. How is ACS using that power of social media to build trust?
That's a really good question. I think that it really just kind of harkens back to the base road to recovery is an option for patients who otherwise wouldn't be able to have transportation to their services, to their cancer screenings and treatments to be able to do so. When it comes to utilizing social media, we do consistently utilize social media to spread information on updates to statutes such as the colorectal cancer screening age recommendations lowering from 50 to 45, and not only releasing them in English, but also releasing them in Spanish as well. Knowing that, English and Spanish are not the only two languages spoken here, we know that we do have a lot more work to do to ensure that we're reaching the communities that do need to hear us. And then, harkening back to some of the comments earlier about, like, I thought a colonoscopy was a man thing. It's like, if you've got a colon, you need to get a colonoscopy at age 45. And just really making sure that that is available in English, Spanish, Cantonese, German, whatever languages that people speak, we need to make sure that that information is available to these communities so that they're able to take control of their health. And when it comes to utilizing social media in really new and innovative ways, that's something that we also need feedback from the community on, of like, what is it that's really going to like drive that? I've got, I've gotten a little bit of feedback from just my volunteers, but in terms of like wider nets of feedback from community members, that's something that I honestly have not ventured to do myself. It is something that is on my list of items that I know would really deepen my impact in the areas that I serve. So that's one thing that is on my mind. And I guess that's just a long way of saying, like, it's just going to be an evolving process that's based on using trusted science, using trusted resources, and disseminating that information to the communities that need it. And I hope that that's, a step in the right direction, but I don't know if anybody here on this panel has any, concrete examples of ways that they've established that type of trust, other than just, as Luz and Dolores were pointing out, like providing the services first before you ask for something. I don't know if anybody has any additional insight on ways to grow that trust.
I just wanted to throw in one of the things that we've done through our Salud.to program is and what some of our panelists have said is we utilize role model stories. The community has the answers to many things, and so we go and help identify who are those individuals who are trusted by the community to kind of be a source to deliver that information for them. In our case, we call them either Salud heroes or role model stories to share how they overcame some barriers to be able to access the care that they need. And this is based on a theoretical framework that we've used for many years, but it's really been important for us to individuals see someone like themselves, and so that we can increase the self-efficacy. So that if that person was able to do it, maybe I can do it as well. And so we have found that type of messaging not only builds trust, but also encourage motivation and action. And that brings me back to Megan. Megan, I think the work that you're doing with the AIR Alliance is really very special. And so could you tell us a little bit more about the different communities that you're working with?
Absolutely. Thank you, Dr. Ramirez. And just to play off what you just said, that's something that stayed with me since my original work as a coordinator, how patients will change behavior. And those patient stories help people think differently. But the Advancing Inclusive Research Site Alliance, as you know, has 4 founding partners. And we knew that we've been working in inclusive research and trying to improve representation in clinical trials for Black and Latino patients for quite some time. And only like AD, a lot of headway still need to be made. I hear folks bringing those trials to the patient. How are we doing that differently? We felt we really needed to work with partners who are doing this well now, who are reaching their communities. And Mays Cancer Center is one of them, really helping us with perspective and building culturally competent materials. I think that's a big place to start. You go back, I looked back, I had great, what's a clinical research study, animated video that looked really cool. And I went to look at it. It had been done 10 years ago. And it looked like they were all white male doctors and all white female nurses. And I'm like, there's no representation. Completely need to resurface everything we've created and create things that are culturally competent. And we can't do that in a bubble. We need partners. It's ACS with your screening. It's Mays Cancer Center with your perspective and cultural competency, patients directly. So we're ensuring our patient co-creation council, it's about 150 strong, have diverse representation and bringing representation lens to everything we're doing. As far as cracking that nut for constantly folks are telling them, make it shorter, right? Make it 3 minutes. And I'm like, what can I do in 3 minutes? But those patient stories help with the perspective. So we have a 10-minute video we're working on for HCPs, and we'll get a 3-minute out of that. And Kyle, would love to continue working with you. And I see the Facebook and WhatsApp, and where's the right place to put this so people feel comfortable? And we work a lot with patient advocacy groups because, you know, what patient's going to go to a pharma website to find out information about the disease, right? They're going to go to other patients. So in trusted sources and really leaning into the trusted community members to make sure we're hearing and changing what we put out there. But Airside Alliance is great. We're learning a lot from our 4 sites. They're all reaching communities in a different way. And just one last example, Dolores navigation has been key. And I see that in the trust example too. How are we creating more of you and amplifying navigation? So as soon as a patient is diagnosed with something, whether it's cancer or Alzheimer's disease, they have someone who helps them navigate social support, financial support, even, you know, a huge hospital system. We've learned from our sites already, understanding that's so important, and creating a budget blueprint for that in our studies for enhanced patient support. Still a pilot, we need to grow it. And I'm with Kyle as well. This is a lot of long-term work, celebrate the successes, but continue to listen. But the educational materials, Dr. Ramirez, you've been critical. You and Dr. Shalila at Mays, very appreciative of your insights, and it would not be what it is without a partnership with folks who understand community. So thank you for that.
No, thank you so much for eloquently stating that. I appreciate it. Thank you. Back to Kyle. Kyle, how has your own, and Megan, you shared with us your cancer diagnosis, and Kyle is also a cancer survivor. How has that experience informed your work?
It has really given me a perspective that I would not have had otherwise. I mean, it sounds like a cliche of, you know, you don't know what cancer is like until you're going through it. And I really only know what testicular cancer is like. And, you know, I'm really fortunate that I had the example of my grandfather who passed away before I was even born, of like knowing that this was even a risk that I could know. Because when I first felt the lump on my testicle, of just knowing like, like I've heard this story before, and then being able to utilize that as a chance to really take control of my health and take control of my own well-being. Now, as a patient advocate, I'm able to have some of those nitty-gritty conversations with patients that people who have not been survivors or have not gone through cancer themselves would feel squeamish, or they'd feel that question's inappropriate. But, you know, for me, it's not that this is the club that nobody wants to be a member of, but when you're in it, you understand so much more about what goes into cancer care, and you'll understand that it's not just diagnosis, treatment, then you're done. Because it's, you know, the diagnosis and the treatment, like that is phase 1, because the rest of your life is going to be an uphill battle from there, because there's going to be anxieties every time that it comes to screening. There's going to be anxieties every time that it comes to any sort of like financial conversations of like, man, that really like put my family out last time. Like what happens if they find something again? And, you know, those conversations are the really tough ones that people don't want to have, because we get so caught up in the moment of thinking, oh, they are in remission, like, you know, and ring the bell and, you know, sending the confetti, everything's great. But it's trying to like understand that there are like long-term consequences, not just with surviving, but just with understanding that this is once you're in it, you're in it. And these anxieties, I don't know how to get rid of them. But when it comes to advocating for patients, that's a way to turn that anxiety into action and turn that anxiety into inspiration for others to know that your story doesn't have to end when, you know, your protective bubble when you're going through cancer treatment dissipates, that it doesn't have to end when you get to ring that bell, and that you can use your story to improve the lives of others. And I really am appreciative of the mentioning of biomarkers several times through this series, because right now that is our next top priority here at ACS Can Texas, is expanding access to biomarker testing and really trying to find how we can create targeted therapies based on a wide swath of biological samples from patients of any background that you can think of here in the great state of Texas. And using my experience as a survivor and knowing kind of like the pricks and prods that go into this and the anxieties and not really knowing what result you're going to get back, being able to have those quality conversations with people has really enabled me to, I guess, really expand my own horizons, not only professionally, but personally as well. And it's really sharpened my ability to think outside of myself and really think about how, when this person is sharing something with me, like, I'm not just like callously thinking of it as a transactional thing. Like, this person is sharing a piece of their soul with me. They're sharing a piece of their life with me. And in some cases, they're sharing the lives of their families with me. And that is a big responsibility to take on. And it's a big responsibility to take on when you possibly fail in the legislative action. And these people could possibly feel like their story didn't add up to anything. But being able to, as a survivor to survivor or patient to patient, be able to have that conversation of letting people know every single time you share your story, it means something. It means something different to every person that you share it with, but it means something. And that's one thing that I hope that people who do volunteer with ACS can walk away feeling, whether they're a survivor or a caregiver, you name it, wherever they land in the cancer sphere, that when they share their story with us, that it's never for nothing. Even if we don't win our big victory at the end of the day, it's never for nothing, because they inspired someone on their team to be like, I'm going to think of Dolores every time I go into that building, or I'm going to think of Kyle every time I go into that building. And, you know, even if they like move across the state line, that inspiration sticks with them. So, and I don't know if that answered your question, but I feel like it did, like,
Yeah,
vice
no,
versa, y'all.
definitely. No, it's
Yeah.
just, you know, because I know that, you know, you were diagnosed fairly young and not, you know, as a male Latino, and we're going to have a special series on cancer and Latino males, but, you know, it was it had to have totally caught you off guard. You know, and so then just now thinking about that and how you share, as you were just saying, your story with others and how important that is. So thank you so much. I appreciate it. So Dr. Garcini, what has been the most valuable lesson that you have learned in your work in working with the Latino community?
Oh, wow. Well, I think I'm going to give you an example with that. When I was doing one of my first studies working with undocumented immigrants in the border, you know, as an immigrant myself, you know, I didn't look like this 25 years ago when I came to this country. I knew my people. You know, I was speaking Spanish. I was using dichos to connect with people. I knew the immigration experience, and I went into the field and I asked them, who would you be willing to sit down and talk to them about your life, or talk to them about your experience, knowing that fear and mistrust is big. And they look at me and they say, not you. And I was like, oh, what? You know, being of the same country, speaking the same language. And they said to me, you look white and educated. And to me, it was a big eye opener of the importance of being humble in our approach, of acknowledging that everybody, like I said it before, is their expert in their own history, and that we need to listen to our communities, to tailor our protocols, to tailor the way we access them, to tailor the way we provide health services if we are ever to close the gap on health inequities. If we continue to think that it is us who drives the agenda, we're going to fail. So unless we change that power dynamics, I just don't think that are going to change. But this is a great time to start moving us in the right direction, to start waking up and to start listening to the communities, listening to patients, listening to people like Dolores, who have their foot in the ground to make a change.
Thank you so much, and a nice segue to Dolores. Dolores, in working with our patients, you know, how have you facilitated them getting access to certain services, whether it was transportation or, you know, maybe they hadn't qualified yet for insurance, you know, how have you been able to link those social services that our patients might need?
Right. It's something that we certainly have to prepare for ahead of time. And we are caught off guard at some points whenever we have a patient call and they say, it's a new problem that we haven't encountered before. So this is how we keep building our little database of resources is we encountered the first patient who had the problem, and now we have a list of resources to offer for them. And then the next patient has a different problem, and that's how we start building our little database. But sometimes we will get caught off guard by a new problem that we haven't heard before. And so typically we try to have, like I said, a database of organizations, and we definitely don't say, hey, call this number or email this person. We say, I'm going to call for you if you're okay with that, because they're already probably feeling some sort of burden from the condition that they're in, the issue that they're having. And so we don't want to add more burden to them. We want to make them feel like we're going to take care of the problem for you. I think that's a big thing that we emphasize a lot in our community health workers, and the way that they help our patients is to make them feel like I'm going to take care of this for you, so that we alleviate some of that burden. And so we'll go into our database. If we have the community resource in there, then we'll go ahead and make that call for the patient. If it's something new, then we'll go ahead and we'll go to Google and we'll call a friend that we know from an organization and say, hey, I have a patient who has this issue. Do you know another organization that might be able to help them out? And then they'll connect us. And so now we're building this network between organizations, right? Or if not, if we don't have a contact somewhere, plain old Google will get us somewhere making calls. If it's something with insurance, we also have a database of organizations that we reach out to first. The issue with insurance that we always run into, though, is that they always require an income, right? They always require proof of income. And some patients are like, yes, I can give you my husband, I can give you my own, and they'll qualify, but some don't have it, or they do have one and it doesn't qualify, it doesn't make them eligible. So now we have this group of people who aren't eligible for these welfare programs, or for these programs that are supposed to help the uninsured. And so now they're in this new group, and we have to really reach and try to find, resources for them. And so it's definitely it's not a 1, 2, 3 ABC 1, 2, 3 process, but it is, we eventually make sure that we get the patient the resources that they need.
Great. Well, thank you so much, Dolores. What a wonderful conversation with all of you. I really appreciate your time. And I'd like to maybe give you all, just a few seconds to give a last statement that you'd like to share with us. So, Megan?
Yeah, Dr. Ramirez, I'd like to make it personal. Dr. Garcini, you talked about humility, right? And I've worked in clinical research for 20 years. You start to feel like you kind of know what the problems are. And I'm such a new learner, and did not, despite intersectionality, single mom, no money growing up, the dollar during college to try to figure out if I could afford that. I thought I knew inequity, but being in the Chief Diversity Office has really just woken me up to the health inequities that so many populations are suffering from. And I think of our Black and Latino populations, and we really need to learn how to stand up in spaces. We, folks like me, who are white, growing up privileged, need to learn how to speak up and stand for others. I'm learning, ask for grace and space. I completely appreciate the space that's being offered for people to have tough conversations. I saw the trust question, unconscious bias. We all need to lean into those tough conversations. And I just invite others to continue to do that and have conversations like this, so we can we're not all at the same starting line, but we all want to be at the same finish line. So how do we help each other? So that's what I'll leave a challenge with for the room. But thank you for letting me hear and listening to everyone. Really appreciate it.
Thank you so much. It's beautifully said. Thank you, Megan. Kyle?
Yes, thanks again for having me as part of this panel. This has been a really great discussion, and I feel like I've learned a lot in a really short time. One thing that I would really like to highlight is that, the work of patient advocacy is, I don't want to say unfortunately never over, but unfortunately, like, the work of patient advocacy is ongoing. And it's not just going to be in legislative spaces. It'll also be in the spaces of community health workers. It'll be in the spaces of social workers. It'll be in the spaces of anybody who has any interactions with a patient and they want that patient's quality of life to be improved. And in order to make sure that your voice is heard, to make sure that your community is heard, you have to, someone has to step up. Someone has to really have the gumption to come forward and have that vulnerability to share their story or share the story of their neighbor or of their friends, their mother, someone who means a great deal to them. And so we at ACS CAN, we welcome anybody and everybody who has a vested interest in improving the lives of folks who are impacted by cancer. So at any point in time, if you want to go to fightcancer.org, you can look up action items that are in your area that would directly impact cancer patients. And even if they're not necessarily in your area, we also have federal action items available at pretty much all times because the federal sessions are ongoing. And I really appreciate being a part of this discussion, because I do think that it all starts and it all will circle back to the community level, but it takes people stepping outside of their community and making their community visible for us to really make some large scale changes that'll impact other communities as well.
Great. Thank you so much, Kyle. And Dr. Garcini, just real quick, because we're running out of time. But
yes, absolutely. I mean, the past 2 years have taught us many lessons. So
oops. I think we just
for advocacy. Everybody can advocate in some way. So I invite you to think, what are some of the ways that you can create culture change, that you can speak up, that you can create platforms to destigmatize marginalized communities and help us move forward. Thank you.
great. Thank you. And Dolores, just very quick.
Yes. Thank you so much. I'm so glad to have been a part of this group of trailblazers. Honestly, I've learned so much from all of you, and it was really great to be here. And I think the last thing, I'm a huge advocate for CHW integration in the clinical setting, whether it's in the Mays Cancer Center or your PCP office. And I think that's something that we have to move towards a lot more, and making sure that we are providing the patients the opportunity to speak with someone that might be able to put themselves in their shoes a little bit better, and be that bridge between provider and patient.
Yes, so thank you. What a wonderful panel you all have been. I really thank you for your time and being with us and addressing this important issue. Our next webinar will be in April of 2022, and we're going to be focusing on overcoming implicit bias in the doctor's office and in research studies. So please, those of you who are with us in the audience today, please share our efforts, and we hope that more folks will join in the future. So again, really want to thank a special thank you to our panelists for all the hard work that you're doing and for being with us today. Thank you so much.